Hello and welcome to RCSI MyHealth Series. In this series we are going to discuss understanding and managing chronic pain. I'm Professor Helen French and this MyHealth Series explores a range of topics related to people's health and well-being, and we bring together some of the recognised experts in the field to discuss these topics with the hope of empowering people and giving them the knowledge to be able to make informed decisions about their own health and well-being. This series was recently announced as a winner in the Best of Europe Region Awards 2024 by CASE, the Council for Advancement and Support of Education. Today I'm joined by Dr. Pádraic Dunne, Senior Lecturer in the Centre of Positive Health Sciences, RCSI University of Medicine and Health Sciences, Ms. Catherine Flanigan, Patient Advocate for those living with pain, Professor Suzanne McDonough, Professor and Head of School of Physiotherapy, RCSI University of Medicine and Health Sciences, Dr. David Moore, Consultant Pain Specialist, Beaumont Hospital and RCSI Honorary Clinical Senior Lecturer. This area is very broad, and whilst we don't have time to talk about all aspects of understanding and managing chronic pain, we have asked our experts to share useful resources, and these will be available on our resource page. Catherine, thank you for joining us here today. So can you tell us about your experience of living with pain and how it impacts your everyday life?
Well, I'm Catherine Flanigan, first of all, and I'm married. I have 2 children and 3 grandchildren. I live a very active life, but in my mid-50s, I developed severe pain in my left knee, swelling. At times it would go from under me with no warning, stiffness. I still have a lot of pain on the medial, on the inside of my knee, the lower part of it. At times, if I'm crouching, I find my leg is sort of, my knee would be enlarged. I find it hard to bring my heel back. So at that time then I went to the doctor, and eventually I had an MRI in the sports clinic, and that revealed that I had degeneration of the bone and Baker's cysts. So then started my rehabilitation. What was I going to do? So initially then I started with physiotherapy, intense physiotherapy with a lot of band work. I also was on medication. Diphene at one stage worked really well for me, but I found it really hard on my stomach. But it was devastating. You know, I spent all my life being active and outside, and then I had nothing. I know what was I going to do, where was I going to turn? And then I came up with the idea, well, maybe I could go swimming. And I joined the K Leisure in Naas, and I started swimming. It was non-weight bearing. It wasn't affecting the knee. So that's where I started, and that was the start of another chapter.
Great, and thanks Catherine for sharing that with us, and we are going to return to your progress and your journey with your pain. But at that time, you know, you've told us there how you were really, really active, and then you went to somebody who had suffered this quite severe pain. In what aspects of your life did it affect you? Like, how did it affect you in everyday life and everyday activities?
Well, starting in bed at night, you know, I had very restless sleep. When I turn in the bed, well, especially my inside of my left knee, rubbing off of the other knee, very, very sore. I get up in the morning tired. And then at that stage, I couldn't trust my knee. I never knew when it was going to go from under you. So if there was cars coming, I'd have to make sure the road was really clear before I attempted to cross the road. I wouldn't be, you know, darting across. That was definitely, I noticed that a lot. I would be very cautious about crossing the road for fear my knee would give way with no warning. So I would be very, very careful crossing the road. I wouldn't take any chances to run across because I wouldn't depend on my knee.
So it really was impacting you really in your everyday life?
Oh, absolutely. But I had nothing to do. I felt I had no purpose. You know, that was the biggest thing. Yes.
Yeah, great. Well, we're going to return to your story later, Catherine, but I'm going to turn now to David and to talk a little bit more about chronic pain and how it presents. And sometimes we hear this term persistent pain used. Can you explain if there's a difference between persistent pain and chronic pain?
Thanks, Helen. They're both the exact same thing. Chronic pain is maybe an older term, and we're trying to use persistent pain now because it kind of sums up what we're talking about. So chronic pain is pain that's been present beyond the healing where we'd expect healing to take place. Or beyond the time frame when we expect healing to take place. So we'd normally put a label of 3 months on that. So if pain is present beyond 3 months, we call it chronic pain. Persistent pain means more to patients and other clinicians because they understand that it's persisting. Sometimes patients use chronic to emphasize how severe the pain is, but that's not necessarily the right way of using the term.
And what causes chronic or persistent pain? Like, how does it develop and then how is it diagnosed?
It's so important to understand because our research in this area and our understanding of how to manage chronic pain and help patients manage, the number one kind of step is to try and help patients manage or understand where it's coming from and how it develops and how it perpetuates itself. So to understand it fully, we have to understand how pain itself occurs and what the function of pain is. And the function of pain in all of us, in every situation, it's a danger signal to try and protect us from potential harm or actual harm. And so when we talk about acute pain, which is the pain we're all familiar with, if we stand on a pin or grab a hot plate, we have these little receptors all over our body that are stimulated by heat or pressure or stretch, and they send signals along a nerve to our spinal cord. And in the spinal cord, those signals are taken up and transferred by other nerves up to the brain. And in the brain, a complex set of things happens. So that danger signal is one piece of information that the brain takes, but it uses other pieces of information as well. So things that we see in our environment, our memories of previous episodes and experiences we've had. It processes all of this information. It even looks at our stress levels, our mood levels at the time of the injury, and the brain decides how much pain we experience. So when people give out and say, you're saying my pain is all in my head, unfortunately we are, but that's the same for all of us. Pain is always generated and experienced from the brain. And the brain is just regulating and measuring that pain to try and protect us and keep us safe. The problem with chronic pain is that over time, if we have lots of these pain signals constantly coming in along the nerves into the brain, the nerves that carry those pain signals and the areas of the spinal cord that receives those pain signals to become quite sensitive. So things that mightn't be too sore, like a plate that's not that hot or a pin that's not that sharp, can generate enough signals to generate those danger signals to the brain. And the same in the spinal cord. The spinal cord nerves can become quite sensitive as well. And then in the brain, we know our brains are brilliant at learning patterns. So when we're learning a tune on an instrument or when we're learning how to drive a car, initially it's very complicated, but after a while it becomes really easy and second nature. And sadly, that can happen in pain. We can learn patterns of pain. We can learn that bending in a certain way generates pain. We can learn in a certain environment in work, sitting in a certain type of seat can generate pain. And over time, when you do these things, your pain is generated in the brain. And so I hope that kind of gives an idea of the complexity, and that's a watered down version. And when you understand the complexity of it, it kind of leads on to how challenging it can be sometimes to treat it.
Thank you very much for that. I suppose my next question to you then is, if it's that complex, can it be cured?
The short answer, to lead on from the very long answer I gave there, is no. Unfortunately, it can't be cured. But we are very careful with patients to lead on to the next piece, which is it can be very effectively managed. To a point, and Catherine kind of reflected on a few pieces there on the challenges in trying to function in the presence of pain. And so our target always with patients is to say, how do we improve your function? And we can certainly do that very effectively in the presence of chronic pain.
Great. And we will come back to that later on, I think, in more detail for our listeners. So, Pádraic, I'm actually going to move to you next because David has made some very interesting comments there about the complexity of pain, and he talked about how patients often, are told, well, it's in your head. And so we'd like to explore a little bit more about how it impacts our mental health.
Sure, and it's one of those phrases in Ireland that I think is terrible, right? It's just what pervades everything. I'm glad David brought it up because it has a very negative connotation, but it's true in a sense that most of these things that happen to us, even activating the immune system, for example, starts in the head with the thinking process, how you perceive your reality, pain emerging from the brain as well. And we know that the mindset that you might have when you're developing pain or moving into chronic pain has an absolute impact on how you sense pain and how you feel pain. And we know, for example, that if you are having disturbed emotions because having pain on a daily basis is very upsetting for many people, that can have a negative impact on your pain. So one of the things as well that's really common is it's unfair. So pain, acute pain, as David said, you stab your foot or you get pricked by a pin or whatever, that's fine. But if this pain is going on longer than 3 months, that feels very unfair. It feels very unjust. It's perfectly reasonable to be angry. It's perfectly reasonable to think it's not fair, that there has to be some answer to this. I'll have to find an answer, have to find a cure. So people are going to people like David and saying, give me the cure, and then there is no cure. And this kind of negative cycle of emotions starts to ratchet down in the system and make the pain worse. And we can talk about the immune system later, but it certainly reactivates the immune response, which then doubles down on the pain itself. So a lot of things that exacerbate the original pain. And I think the Buddhists have called it the twin arrows of suffering. So the first arrow is the arrow that comes over a hedge and hits you in the chest. And there's a lot of pain with that. But we tend to hit ourselves with a second arrow. We shoot that arrow. And that is, this is unfair, I'm angry, I can't find a cure, I'll have to find some solution to this. And that exacerbates the original pain. So if we can somehow, and it's easy for me to say this sitting here, isn't it? If we can somehow get to grips with our perspective of pain, if we can move one step closer every day to maybe accepting it. Now, not surrendering to it, but accepting it, because maybe there will be some element of cure that will come down the line, but on a daily basis to move towards acceptance changes the mindset to more of a growth mindset, and we can talk about that later as well if you like. That will calm down the immune response, it will calm down the stress response and make you feel a little bit better. It won't take the pain away, but make you feel a little bit better.
And I think we'll definitely come back to that again in relation to management strategies for chronic pain.
Sure.
But just to return to your comment there about the immune system, like how big a role does it have in maintaining or even causing chronic pain?
So obviously David's a specialist in the nervous system and the pain responses in the brain, and I'm an immune system nerd, so it's a beautifully balanced system, generally speaking. And I think it comes in under pain and acute pain, which is the sharp shock. And the chronic pain, it does a lot of things to upset that chronic pain. So it's very helpful initially. And if you think about the immune system, it's billions and billions of little cells like tiny footballs. They live in lymph nodes underneath your arms, in your groin, in your chest, and billions and billions in your gut. And when everything's hunky-dory, just like Goldilocks, everything is great. And if you get an infection or a cut skin, it comes in, it fights the infection, cleans everything up for you and runs away. The other thing it does is that acute pain, as David said, is a danger signal because you don't want to be holding on to something that's really hot. So that danger signal attracts the immune response because you want the immune response to come in and check that there's nobody infecting the area, but also you want to make sure that it can come in and clean up everything afterwards. So it comes in, it helps all the repair, and then for most people it shuts down. And then the pain shuts down and we're all fine. But in chronic pain, lots of different things can happen depending on the type of thing that's occurring. So for example, you can have the immune response, the immune cells themselves produce chemical messengers that go out into the blood, and those messengers can go up into the brain and activate the brain centers. Or if those centers are activated already, they can further activate them. they also talk to the ends of nerves. So the cells themselves, you could see them in a microscope actually converging around the end of nerves and tickling each other and talking to each other with these chemical messengers. That can make everything worse long term. And then you have the kind of collection of diseases that, for example, Catherine mentioned diphenine. So that's an anti-inflammatory, and some people would have to take that if they had, long-term injury or if they had an autoimmune disease, where the immune system now thinks that a piece of cartilage or collagen in your knee is actually a piece of a bacteria or a virus. And it makes that mistake. It starts attacking, starts producing those chemical messengers. And that's going to make all the pain worse. So that's why things like diphenine can help calm down the immune response, calm down the pain. But then there's a fourth, more insidious problem, and that is stress. And because you've got pain, of course you're going to be stressed. Of course you're going to have emotional dysregulation, like the anger, upset, things like that. And even your thinking process and your emotions can activate your immune system within nanoseconds. So you will get adrenaline produced from your adrenal glands, starting with signals in your head. And that will activate all those little cells that live in those armory barracks in the nodes all around your body, and they'll start producing chemical messengers. 15 minutes after that, you'll get the stress hormone cortisol produced, and that's there to shut everything down. So that's why you'd put hydrocortisone cream on your skin to get rid of a rash. And that's fine if it's a short period of time, but long periods of time with stress, we get a dysfunctional response. We get exhaustion of cortisol production, and that leaves a dysfunctional immune response that's out of control. And then that makes all the original pain worse over a long period of time. So for me, one of the key things, as strong as far as I'm concerned, almost as something like diphenine, as an anti-inflammatory, is regulating the stress response. For me, if you can't cure that, you certainly try not to shoot yourself with that second arrow that creates that stress response. But that's not easy. It's easy for me to say that here now. That could take a lifetime to manage. But for me, that's key.
Thanks very much for that. So Suzanne, we're going to move to you next really to talk about the impact of chronic pain on physical activity.
Thanks for that, Helen. So we know from many studies that have measured physical activity levels in people with chronic pain, and Catherine has even mentioned it herself, is they're much less active than the general population. And there are many reasons for that, but one reason is that people start to fear that it's the movement that's actually making their knee flare up or causing more damage to their tissues. So it's a natural instinct to avoid movement in order to avoid pain. But we know with chronic pain that actually pain on movement is not a good indicator of the health of your tissues, and that actually moving with pain shows your body that it's actually safe, the pain is safe, and then you start to fear the movement a little bit less, and that actually leads to reductions in your pain. And that's one of the reasons why physical activity and exercise is universally recommended in in clinical guidelines for many chronic conditions.
And apart from physical activity or exercise helping pain, does it have any other health benefits?
Yeah, so there are many benefits, and many people in the population will have heard that, and people with chronic pain have heard that as well, about it also helps to maintain your wellness. So it has both immediate effects, so a single bout of exercise can reduce your blood pressure, it can help you sleep better, it can reduce your anxiety levels, but if you keep being active, it will have long-term effects on your brain health, your bone health, it'll also help to prevent certain cancers from developing.
So really, physical activity does sound like a nice catch-all approach. Thanks, Suzanne, for that. So, Catherine, I'm going to return to you again, because we've now heard from Suzanne about how physical activity is really important in managing chronic pain, and how movement is so important. So can you tell us, how important is exercise to you in your daily life? Because that seemed to be the thing that really helped change your management of your chronic pain.
Well, I would say physically, I'd say I am stronger, fitter, my posture is better, everything since I got the injection and could do the exercises. I'm definitely a stronger, better person. And I just feel every other day I nearly have a trip. I saw somebody nearly tripping today. You know, the footpaths are uneven and that. And I just feel if I'm strong, I'm able to support myself. You know, that you think you were going to trip, and next thing, you're able to balance yourself and get back up. Mentally, I love the challenge of doing the exercises, being in a certain place at a certain time. I love that. If I'm physically stronger, I do go on holidays every year, bring my grandchildren with my husband away, and I don't sit in the chair and watch them playing. I do the swimming, I do the hurdy-gurdies. I'm able to do all of that with them, and I'm really grateful that I can do that. Socially, doing exercises, I'm a real social person. I love being part of a group, and I find when I joined the Naids Triathlon Club, the women were really good for me. They pushed me and they encouraged me. I was much older than the vast majority of them, but I love being with younger people. I think that's great. I've done the Ring of Kerry on the bike with that group. I've the Ring of Dingle, the Ring of Beara, all of that because of the group. But I mean, I feel I'm an exception to the rule, and I'm very grateful for that. Had I not met Dr. Moore and had the injections, I'm sure I wouldn't be as good as I am today. So a day never passes that I'm not grateful that I'm doing so well.
And just to return to that, so you went to see Dr. Moore in his clinic in Beaumont. He prescribed the pain relieving injections, and from there, was that the step that allowed you to start exercise? Maybe just talk us through that journey from hardly being able to cross the road to then being able to now get to a stage where you tell us you're doing amazing levels of physical activity.
Yes.
With this pain.
I've had 2 injections with Dr. Moore. Now, they weren't nice. You had to have, I had nearly a general anaesthetic. I had to go to theatre, be driven to the hospital and collect it. But the first injection, I could honestly say it was like instant pain relief. I'd say now the site of the needle, I gather, was a big needle, and he was looking around as he was doing the injection. So the site of the injection was very sore, but that internal pain, the burning sensation, that was gone, I'd say, within 2 days. And that injection lasted for, I'd say, approximately 6 months. But that gave me the start to start doing the exercise, doing the weights. I downloaded the Couch to 5K, walked 1 telegraph pole on the canal, ran 1, then walked 1, ran 2. That was the foundation. I wouldn't have been able to start. You know, I had the foundation because I was not pain-free, but I was much more mobile after I got the injection.
Okay.
So that enabled me to continue progressing in my fitness.
Great, well, thank you for that.
Thank you.
So David, we've heard there from Catherine how she suppose was able to start this regime of exercise and being more active, and how that has helped her manage her pain. So what are the main pain management strategies for somebody who presents with chronic pain?
So we've heard about the 2 big ones so far. We're talking about the exercise and confidence with moving, and we emphasise that, and also we emphasise the importance of understanding your pain, understanding where it comes from, educating yourself about what the triggers are, what helps in managing it. And if we look at all the chronic pain guidelines, doesn't matter what type of pain syndrome we're talking about, they're the 2 big ones at the top of the list, is an understanding and education, and exercise and activity. And I suppose if we were recording this 10, 15 years ago, we may have been talking about medications, injections, surgery, and they do have a role, but in isolation. Catherine described it very nicely, and I don't want to take credit for her amazing progress, because most of that is self-driven, but an injection in isolation isn't going to produce the kind of results that she's achieved. Whereas her commitment, her understanding, and her support from her physiotherapist, etc., has got her to this point, with maybe a help from one or 2 injections. If we look at the other big treatment strategies that have very good evidence behind them, Pádraic mentioned one of them was stress management. And our psychologists in Beaumont Hospital are particularly good in leading those treatments, and we look at things and we think about things like mindfulness-based stress reduction programs, which are very nicely structured programs. Normally psychologists run them. Sometimes we have some of our physiotherapy colleagues who run them as well, and they are extremely effective in dialing down stress levels, and we see huge response in improvements in pain in those patients. The other type of strategies we look at are sleep hygiene techniques, and again, chronic sleep deprivation, Catherine alluded to it earlier on, nights and nights and weeks of lack of sleep will make you feel terrible in every sense and will increase your pain levels. So straightforward sleep hygiene techniques for patients who are more complex, insomnia-based kind of CBT approaches are extremely effective. And I'll give you one more. Work and activity, trying to maintain work practices and activities in patients who have persistent pain or chronic pain is really, really challenging. So trying to support that, making sure that people don't fall out of work. We do a lot of communication with employers in trying to support people, maybe working part-time while they're trying to rehab, but not falling out of that practice. And any activity in general, even if you're not working, minding your grandchildren, helping out in the local charity or volunteering, maintaining that activity is important for your physical and mental health.
And are there any limitations to any of these approaches? You know, you've mentioned a number of them there. You've mentioned the psychological approaches, the exercise-based, the medications. Are there any, downsides of these?
I think the biggest limitations are your expectations going into it. I think patients come to us in our clinic, and sometimes they come from their GP or their physio with the expectation that they will get a fix and that they will leave the clinic with a guaranteed fix. And obviously when we go into the complexity of it, people are disappointed. So when we're prescribing treatments for patients, whether we're sending them to the physiotherapist or to the psychologist or organising for injections or prescribing medications, we try and set their expectations so that they understand if they get a small improvement in each area, whether it's in the biological sphere, the psychological sphere or the social sphere, if they get a small improvement in each area, they have to convert that into increased function and a better quality of life. It's important to talk about medications when we talk about limitations, because obviously medications are extremely popular treatment strategies, and they do work in many patients for a short period of time. And Pádraic mentioned about the immune system and the inflammatory processes, and we use the non-steroidal anti-inflammatories like ibuprofen, diphenhydramine, Vimovo, naproxen to manage these type of pains. And what they do is they reduce the chemicals released in the inflammatory process in the joints and in the muscles, and that can reduce the pain for a short period of time. The problem is those chemicals are also important in regulating blood flow in the stomach and in the kidney, and so if you're taking them regularly every day for weeks and months, you can cause stomach ulcers and kidney damage. And sometimes our patients don't appreciate that, or they don't realise that. The other big medication that we have to address is the opioid-based medication. So these are the ones, like we call them the morphine-like drugs. So codeine is one of them. It's converted into morphine. We have tramadol, Palexia, morphine, OxyContin and Oxynorm. And these drugs are very strong. They're excellent painkillers. And if I have a surgery or if I have very bad pain, I want these medications. But unfortunately, in the long term, a bit like the other painkillers, they have side effects. So they create constipation, they have impacts on your mood and your motivation, and they can sometimes lead to depression. They have impacts on your hormones, so they can accelerate osteoporosis. They increase your risk of falls and accidents. And in some situations, they can actually amplify your pain over time, so you get chronic headaches and kind of widespread pain from them. So I think it's important to address those two big ones and say they're excellent for the short term to get you moving and going, but in the long term, they're not great options.
Mm-hmm. So I suppose then to think about moving beyond medications and looking more at maybe lifestyle, I think that brings me back to you, Pádraic. Your expertise is in positive health. So I suppose maybe explain to our listeners what is positive health and what role can it play in managing chronic pain?
Sure, thanks, Helen. I mean, I think David and Catherine have already described really positive health in a great way. It's a new and emerging field, but it's an old story. It's practical common sense that our grandparents and their grandparents all practiced. And really, if you can imagine, so there are a number of different areas. So one is lifestyle medicine, and I'll go into that in a bit more detail in a minute. If you got lifestyle medicine, mix it with positive psychology, a bit of behavior change science and health psychology and put it into a blender, you'd get positive health sciences. The important thing is that it's evidence-based. That's the important thing, because there's a lot of stuff out there that's not evidence-based. When we focus on lifestyle medicine, and again, you know, everybody here has already spoken about the elements of lifestyle medicine, 6 pillars, and we're talking about exercise, physical activity, eating whole, healthy food as best you can, sleep hygiene, hugely important for pain, obviously. Then you're talking about, and something that everybody forgets is cultivating positive, healthy relationships with not just with our family and friends, but in our community, because many of us feel isolated even in our communities. I think COVID taught us that. Another thing related to pain, I think, and unfortunately, and I can understand why people would reach for alcohol, but alcohol is very, very negative in terms of pain, long term, obviously. So alcohol and tobacco is a big pillar in terms of lifestyle medicine, as in reducing that if you can. And then the biggie, stress management. How do you do that? And when you combine all those things together, you get lifestyle medicine. And one of the beautiful things about lifestyle medicine is that it's kind of like a rising tide lifts all boats. So if you can improve sleep, you're more likely to get a bit of exercise the next morning, which means you're more likely to be less grumpy with your kids, which means you're less likely to reach for the second glass of wine in the evening, which means you're less likely to reach for a pizza at midnight, which means you're more likely to get sleep. And around it goes again. So it's a beautiful thing. You don't have to go hell for leather. Small changes, better health, incremental, day by day. So that's the lifestyle medicine part of positive health science. Then the other part is the positive psychology, and that is the science of human flourishing. If you get human beings who flourish, so professional athletes, musicians tend to be really good examples of that. What's the evidence behind those individuals? What makes them flourish in all these different aspects of life? And how can we, average mortals, replicate that? That's positive psychology, really. And elements of positive psychology that are helpful, I think, for pain include things like growth mindsets. So I don't know about everybody here, but I was born with a fixed mindset where I believed that I had talents in a box and that was the end of it. At least that's what the nuns told me anyway. And it's only been relatively recently that I kind of shook that into a growth mindset. And there is an American professor called Carol Dweck, and I would urge anybody watching or listening to this to buy her book. Carol Dweck, D-W-E-C-K. And she is the world's researcher really in a growth mindset. And she's written a very accessible book that I think every kid should be asked to read, but we should all read it. And when you cultivate a growth mindset, it means that failure is an inevitable part of life. Suffering is an inevitable part of life. And if you incorporate that kind of philosophy, now again, Catherine, it doesn't mean surrender. It doesn't mean that at all. It means managing and being positive, and not in a silly way, and not having silly optimism, being realistic and pragmatic, but nevertheless having a growth mindset, allowing for failure, allowing to fall off the wagon, allowing yourself to have a bad day. Really important. And underpinning that then is self-compassion and trying to deal and manage with the inner critic that always crawls up and says, well, maybe you should be going for the OxyContin, or maybe you should go and ask David for some more meds, or maybe you should be doing this, or maybe you shouldn't look like that. Or a great one, I think, for pain is you shouldn't have to put up with this. It should get better. And these are all shoulds, but they're not part of reality, you know. So positive psychology deals with all that. And then the third part is behavior change. because it's all very well and good for us to be told, lose 2 kilos, eat more healthy food, get more sleep, but how do you do it? It's really hard. There's a reason why we all fail at the end of January, New Year's resolutions, because it's really hard for human beings to do something again and again and again and turn it into a real habit. So the biggest key message that the behaviour change scientists would say would be to keep it small, to keep it achievable.
Mm-hmm. And we're going to, I guess, come back to some practical ways to do these later on. But I'm going to go now back to you, Suzanne, and pick up on one element of the lifestyle medicine, which is physical activity. And, you know, Catherine has mentioned things like triathlon, and she's mentioned the Ring of Kerry, and these are big, big activities. But, we know that a lot of people listening and a lot of people who have chronic pain are not doing that and probably can't even think of doing that. And a lot of them are not physically active. So can you talk to us, I suppose, first of all, about, the levels of physical activity that we want people to be at, or, about this issue we have with people being sedentary, probably too sedentary now in their lives?
Sure, yeah. So there's a couple of elements to your questions there. So I suppose maybe I might start off by saying, I think, Catherine, obviously you already were active before your knee became painful. And I think that's really helpful when people have already had a positive experience with exercise and physical activity. But a lot of people with chronic pain don't necessarily have that to fall back on. So they're maybe, have this pain and then they're trying to start to do exercise, and maybe they had a really bad experience when they were in school and they, mitched off all of their, PE classes. So I think the message we're trying to sort of share with people is that physical activity is everything that you do. So it's your housework, it's your hoovering, it's the, traveling to work, it's what you do at work. And really it's trying to find the small pockets of physical activity that you can fit into your day. So certainly in all the work that I've done, and lots of it with people with chronic pain, it's about trying to find that 5 or 10 minutes or the small number of steps that you can fit into your day. And certainly I think the physical activity guidelines, the latest guidelines from Ireland published in 2023 are recommending that people do 2.5 hours of moderate intensity exercise or 1 hour and 15 minutes of vigorous intensity exercise. And I think if you've got chronic pain, many people are very far away from that level. So I tend not to start with that. I tend not to start with the physical activity guidelines because I think it can just switch people off. But the good news about what we know, the guidelines are very strongly based around the evidence, is that for people who are doing very little activity, just even moving a little bit really has a massive benefit for their health. And then the other side, you mentioned sedentary, so it's probably important to define that too. So sedentary has a very specific definition. So it means sitting or lying during the day, and that's sort of where you're very low levels of energy expenditure. And again, the guidelines are saying we really should try and limit our sedentary activity and try and replace it with some physical activity. Now, if you're somebody who's in a very sedentary job, let's say you're spending more than 8 hours in a day, you can offset that health risk, but it's probably doing 60 minutes of moderate intensity physical activity every day. And most of us, even if we don't have pain, would really struggle to fit that into our day. So I think the key thing is, try not to sit for long periods of time, try and get up and move around. And again, people with chronic pain will have heard that message from their healthcare professionals.
And you've mentioned intensity there. You mentioned moderate intensity. Like, what does that mean? How would you define it for somebody listening? How would they know they're exercising at a moderate intensity?
So again, it's relative to individuals, but probably the easiest way to explain it is if you go for a walk with your friend, and your brisk walking is a good example of moderate intensity exercise or physical activity. You might be starting to breathe a little bit harder, you're starting to get a little bit warmer, but you're still able to hold a conversation. And then you get to that steep hill and you're going up the hill, and suddenly the two of you just stop talking because you've started to breathe a bit harder. You might actually be visibly sweating and you're starting to go, I think I might need to take my jumper off now. That's when you've shifted into vigorous. And I think for people, if you're inactive, you'll go into vigorous much more quickly than somebody who's already quite fit. So again, it can be challenging then even when you're trying to choose your buddy to be active with. If you choose someone who's much fitter than you, it becomes quite challenging because you're moving into vigorous way before they are. But that's the way that we would tell the difference between moderate and vigorous physical activity.
And then you mentioned walking as an example of a physical activity, and you mentioned time earlier about what the physical activity guidelines referring to this 30 minutes. How would you convert that into steps for somebody? Because I think a lot of people now think about this number of steps they've got to hit a day.
Yeah. So again, I mean, Catherine has her watch on and talked about wearables, but I think we have this number, 10,000 steps. It's a totally arbitrary number, doesn't really mean anything, but lots of devices will, sort of get you to try and reach this 10,000 steps. I think, again, it depends on someone's baseline. So we all know during COVID, I mean, I live in a very small house, but I could have been doing as little as 1,000 steps in a day. That was kind of my baseline. Now, if I wanted to meet the physical activity guidelines, one of the ways for me to do it would be do a 30-minute walk 5 days a week. And 30 minutes of walking is about 3,000 steps, depending on the speed that you walk. So if my baseline was 1,000 steps during the day, if I did 4,000 steps, I've actually met the physical activity guideline for that day. So it really is relative to what you're doing. So I would always say to people, don't worry about the 10,000, that's not important. It's just important that you're adding steps on to your day in a way that's going to work for you, and very carefully pacing it. Because I think we know, I mean, you mentioned about the effects of drugs, but we are understanding much more around how exercise and physical activity in itself can be a pain relieving agent. And it can both have a chemical effect, so it can actually lead to the release of your natural painkillers, but it also kind of a structural effect over time. It helps to actually remodel your nervous system so that your nerves become less sensitive to input. So I think, certainly continuing to move over time actually will help to reduce your pain if you have chronic pain.
And to come back to the benefits of physical activity you mentioned earlier, which was to relieve pain, you've nicely referred that back to that again, Suzanne. And also you talked about the general health benefits. So how much do we need to do to hit both of those targets for pain and to improve pain and function, but also for our health benefits? Is it the same amount? Does it differ?
Yeah, well, I mean, I'll talk maybe about the work that we've done and the numbers of steps that people did who had pain. So over an 8-week programme, on average, people increased their steps by about 2,600 steps. And during that, they showed a reduction in their pain and an improvement in their functional disability. And we're also learning much more around the general wellness and health benefits. So what's going to protect your heart health, your brain health. And if we look at people who are over 60 years of age, we start to see the risk of early mortality at about 3,000 steps. So it's actually quite similar. So if you're doing about 3,000 steps per day, you're starting to both be able to manage your pain condition, but also reduce your risk of other health conditions like your heart diseases and your cancers and other types of conditions.
Thanks very much, Suzanne. That's really interesting. And I'm going to return now to David. So David, we've heard now about lots of management strategies, and you're in a very specific pain service in Beaumont Hospital. But of course, not everybody with chronic pain goes to see yourself and pain specialists. So could you talk about what situation a GP would refer somebody into your pain clinic in Beaumont Hospital?
Of course, yeah. I work in a busy, large pain management unit in Beaumont, and there's lots of different disciplines working there. We have doctors, nurses, physiotherapists, psychologists, and we have access to other colleagues in rheumatology, spinal surgery, psychiatry. So we see patients who are, I suppose, the GPs and the physiotherapists in the community are very skilled at managing chronic pain. It's a very common problem. 20 to 30% of the population live with it every day. So they're very good at managing it. So we only see the patients who aren't making progress in the community, and the pain is having a really negative impact on their function and their quality of life. Somebody like Catherine, who's progressed to this point now where she's managing it very effectively, she doesn't have to come to see us. But if the GP and the physiotherapists in the community say to us, listen, we're doing our best here, but this person's quality of life is being impacted by their pain, we're happy to see them and try and put a multidisciplinary and multimodal approach in place to try and help them make progress. Great.
So I suppose there's lots of ways that people can try to manage their chronic pain with the support of health professionals, and also that self-management approach, and hopefully our listeners are getting some indications of the multi-pronged approach. But I think now what we'd like to do is really go to all of you and try to, pulling this together, give your take-home messages for our audience. So I'm going to start actually back to you, David. What are your key take-home messages for our listeners?
I suppose I have one key take-home message, that chronic pain and persistent pain is extremely common. All of us at some stage in our lives will probably have to manage it and deal with it. Pádraic mentioned the concept of acceptance, that it's something that's there, that we all have to try and manage and move forward with, and that try not to chase the cure and the fix, because it's exhausting and very disappointing and you feel let down along the process. And instead, I hope we're giving a positive message that it can be managed and your quality of life can be optimized in the presence of pain, and that there's so many resources out there and so much expertise out there to try and help you do that.
Great, and there will be resources available on our resource page for our listeners. So Pádraic, over to you then. What would your key take-home messages be?
So I think first and foremost, it's the multidisciplinary approach. So, you know, for Catherine to be able to have access to everybody in Beaumont and all the different types of team, that shows you that it's not just one thing that solves this problem or gets the person to a certain stage. It's many different expertises, you know, hugely important. And leading on from that then is there's no one-size-fits-all approach to this. So you'll have to put on your own Sherlock Holmes hat and do a bit of trial and error in terms of the elements of a toolkit that you develop. One final thing I would say, apart from just be kind to yourself, is I think it's really important to understand who you are as a person when you're going through chronic pain. I think it's important to know how you react to things like that, because many of us aren't fully aware of who we are as people. And when something like chronic pain starts to emerge, it can be very destructive, can be very damaging to us psychologically. So, you know, you would have great access to psychologists in Beaumont, but they can't live in your house, unfortunately. So my recommendation would be to find a counsellor or somebody you can talk to relatively frequent basis. You know, let's say a counsellor once a month or something like that, that you can check in and use that person to bounce off the reality of what's happening to you. Again, it doesn't have to be a psychiatric thing, it's just about talking. And I think it's really important to find out who you are, what triggers you emotionally, psychologically and physically, really important. But then to re-emphasize the last thing, be kind, cultivate compassion for yourself and mind the stress, because it will make the pain worse.
Okay, thanks Pádraic. And moving to you, Suzanne, what are your key take-home messages for our listeners?
Well, I suppose the first thing I'd say is that I think people need to be willing to give it a go and try out movement with pain, because it actually will make it easier. I think practically you can use something like a wearable, or even just a very simple pedometer or a paper diary, and actually measure how much you're doing over a week, so you can actually see the patterns of your movement. And then a little tip that we've used a lot is actually getting people to walk for 5 or 10 minutes to see how much they can do. Because often people will say to us, oh, I couldn't possibly walk, that's going to make my pain worse. But sometimes when you actually do it, you'll surprise yourself at how much you can do in 5 or 10 minutes. And that might be your first step goal. So you might be able to only do 500 steps in 10 minutes, but you then decide, well, I'm going to try and do that maybe on 2 or 3 days in a week, and gradually build it up from there. And then you avoid that kind of boom or bust thing, and you're kind of carefully sort of taking the baby steps, but in a very practical, controlled way.
Okay, and Catherine, we're going to leave the last word with you. You're the person who's living with chronic pain and has managed to, I won't say be pain-free, but you've managed to not let it ruin your life. So tell us your key take-home messages.
Well, I'm overlapping on Pádraic, to be nice to yourself, to keep the weight down and alcohol down. I definitely know from the watch, it does affect your body battery. I find if the body battery is up, I'm in better form and all of that. Alcohol definitely reduces the body battery. And then my last thing is, don't let the old woman in.
Fantastic, and we can see and hear from Catherine that she definitely has that growth mindset that Pádraic has referred to. So that concludes our discussion today, and many thanks to our speakers, Dr. Pádraic Dunne, Ms. Catherine Flanigan, Professor Suzanne McDonough and Dr. David Moore. Further details about upcoming episodes in the MyHealth series from RCSI can be found at the RCSI website. And you can also find the RCSI series on all major podcast platforms. RCSI is committed to improving human health, and we are proud to be ranked 5th in the world for our impact on good health and well-being. From all of us here at RCSI University of Medicine and Health Sciences, thank you very much for joining us today.